Thank you very much for the kind invitation. So we're shifting the topic a little bit towards ovarian cancer, and we're shifting it a little bit from the focus on immuno-oncology, as that is not that important as in other solid tumors in ovarian cancer. When we talk about ovarian cancer, on the downside, we still have a very aggressive tumor disease. Approximately 60% of our patients will have a recurrence within the first 5 years from diagnosis. On the other hand, we were able to increase overall survival in this patient significantly. Approximately 10 years ago, it was around 18 months, 5 years ago, 35 months, and nowadays we're somewhere between 50 to 60 months. So we're kind of getting it to more and more to a chronic disease. The two mainstays for epithelial ovarian cancer nowadays are still surgery and platinum-based chemotherapy. And for kind of decades, it was a question of sequence, whether we start with aggressive surgery and then continue with chemotherapy, or use 3 to 4 cycles of chemotherapy, shrink the tumor down, then go on with interval debulking surgery and continue with chemotherapy. And there were kind of two game changers in the game. On the one hand, more aggressive surgery, so we were able to significantly increase our aggressiveness in radical surgery with keeping our morbidities still pretty low to reach a higher rate of complete resection in these patients. And on the other hand, maintenance therapy was introduced a little bit more than 10 years ago in epithelial ovarian cancer, and that was really a game changer in this whole concept. When we look at the hallmarks of cancer therapy, and in particular for ovarian cancer, we have kind of 3 access points for ovarian cancer. On the one hand, it is PARP inhibitors that are very prominent in ovarian cancer therapy, VEGF inhibitors like bevacizumab, and we're still hoping for checkpoint inhibition. So when we look at high-grade serous ovarian cancer, which is the most aggressive and the most prominent, most relevant subtype of ovarian cancer, we know that approximately 15% of these patients will have BRCA germline mutations. An additional 5 to 8% will have somatic BRCA mutations. And overall, approximately 50% of our epithelial ovarian cancer patients with advanced disease will have somewhat of a defect of the repair in their system. It's called homologous repair deficiency, HRD. So when we start from the bottom with our well-known bevacizumab and the VEGF, we have several trials in first line as well as in the recurrent setting and in the terminal stage, late stage of the disease in the platinum-resistant cohort. And we kind of get approximately 2 to 5 months out of this bevacizumab maintenance treatment, pretty much irrespective of the line we're using it. So on top of chemotherapy, bevacizumab will give the patient additional of 2 to 5 months. And then it kind of changed the story completely. It was 2017 when the first PARP inhibitor trial, the first relevant PARP inhibitor trial was presented for ovarian cancer patients. It was the SOLO2 trial, looked at progression-free survival only in patients with advanced ovarian cancer, platinum-sensitive recurrence, so good response to platinum-based combination chemotherapy, and with a BRCA mutation. And in these patients, you see the line above is the one with the PARP inhibitor with olaparib, and in the control arm placebo as maintenance therapy, huge difference with a hazard ratio of 0.30, so 70% risk reduction, something we've never experienced, never seen before in our ovarian cancer patients. So that was really a game changer and draw the topic PARP inhibitors in ovarian cancer completely to this focus. And the second convincing argument was when we are looking at the secondary endpoints of this SOLO2 trial, we see that this huge benefit the patient will get out of this PARP inhibitor treatment will stay with the patient for a long time. So time to first subsequent treatment, hazard ratio 0.28. Progression-free survival 2, hazard ratio 0.50. Time to second subsequent treatment, hazard ratio 0.37. So this truly persists for the patient for a very long time and is not diminished by the second or the third line after the PARP inhibitor. And the third argument is that the PARP inhibitors are very well tolerated. When we look at this interesting TWIST analysis, so TWIST stands for time without symptoms and toxicity, you see the more we have here, the larger this area under the curve is, the better is the treatment tolerated and the longer the benefit for the patient. And you see a huge difference between the niraparib arm in this trial and the placebo arm. So very effective treatment in ovarian cancer and very well tolerated. After the SOLO2 trial, there were several other trials evaluating other PARP inhibitors in the same setting, so platinum-sensitive recurrent epithelial ovarian cancer. And if we look at these three bars, the SOLO2 trial, the NOVA trial, and the ARIEL-3 trial, you always see that there's a huge difference between the dark blue bar, which is platinum-based chemotherapy, good response, and PARP inhibitor, versus the light blue bar, which is platinum-based chemotherapy, good response, and placebo. But it is important to be aware that these trials always evaluated BRCA-mutated patients, so be it a germline BRCA mutation or BRCA mutation in the tumor tissue. And when we look at within these trials in the BRCA wild type group, we also see that the PARP inhibitor even works in this group. But if you look at the dark blue bar and the light blue bar and compare it to the first two trials, so the GOG 213 and the OCEANS trial that were the bevacizumab trials in very comparable, similar cohorts, then you see that the PARP inhibitor in the BRCA wild type group works pretty equally effective as bevacizumab. That's important to keep in mind. So it was very obvious to take the PARP inhibitors from our recurrent setting where we can streamline for the patient and they will ultimately die from the disease to the first line setting where we truly hope to make a difference and increase the cure rate for patients. So again, SOLO2 trial, first trial in recurrent setting, SOLO1 trial, the first relevant trial in the first line treatment. And there again, huge difference between PARP inhibitor and placebo arm. When we look at 3-year progression-free survival in the PARP inhibitor arm, 60% compared to less than 30% in the placebo-controlled arm. So again, a difference that we've never seen before in ovarian cancer. So it was, again, very logical to test it in a broader cohort. So not only our patients with BRCA 1 or 2 mutations, but also with HRD, HR deficiency, and in kind of all comers. And that was like kind of for a gynecologic oncologist, most exciting conference, ESMO 2019, where we had 3 trials, first-line trials, in plenary sessions presented, something that you don't experience very often as a gynecologic oncologist. I will focus on 2 trials because they have approval in the European Union. The first one is the PRIMA trial that was run with the PARP inhibitor niraparib in a kind of high-risk setting. So patients had to have either stage 4 disease or residual disease after debulking surgery. So overall, a cohort of patients with a very high risk for recurrence. And within this trial, they were randomized to platinum-based chemotherapy, and after good response, either PARP inhibitor or again placebo. And again, in the all-comer population for progression-free survival, nice hazard ratio 0.62, so 40% risk reduction. And when we look at the median PFS, significant difference, nearly 14 months in the PARP inhibitor arm compared to 8 months in the placebo arm. So really significant difference for our patients. And when we then look into our exploratory analysis and look who are the patients that benefited the most from this PARP inhibitor, then this is kind of a repetitive story that you find throughout all PARP inhibitor trials run in ovarian cancer. The subset of patients that benefits the most from the PARP inhibitor are the ones on the left side, so either with a BRCA or an HR deficient tumor. Hazard ratio of 0.40. The second best group, the patients with BRCA wild type, so no BRCA mutation, but with HR deficiency. And in this trial, in the PRIMA trial with niraparib, even a benefit for patients without a BRCA mutation and without an HR deficient tumor, so this HR proficient cohort you see on the right side. And that is pretty unique for these PARP inhibitor trials. Because then the second trial, PAOLA-1 trial, also first-line therapy, also progression-free survival in overall population. So again, kind of all comers. Within this study, it was a little bit broader, the inclusion criteria. So it was also patients that had a complete resection and with stage 3 that were primary completely debulked. And again, a huge difference between the PARP inhibitor group and the placebo group. But one of the main differences in this trial is that the placebo arm was also done with bevacizumab. So these patients received platinum-based chemotherapy and bevacizumab as a control. And in the treatment arm, platinum-based chemotherapy, bevacizumab, plus the PARP inhibitor. And interestingly, you see that the median PFS is much longer than in the other trial, probably or very likely because it was kind of an all-comer situation. Median PFS 22 months compared to 14 months in the other trial, nearly 17 months in the placebo arm compared to 8 months in the PRIMA trial. Again, very similar hazard ratio of approximately 0.60, so 40% risk reduction. And when we come to our exploratory analysis, very similar pattern to the PRIMA trial. The left-hand side, the patients with BRCA mutation, HRD positive, huge benefit for the patient. In the middle, BRCA wild-type patients, but with an HR deficient tumor, large benefit. And in this trial, patients without a BRCA mutation and without an HR deficiency, so HR proficient tumors, no benefit. Just to stress how important still the role of debulking or aggressive surgery in these patients is, when we look at the PAOLA-1 subset analysis and look at the cohort of patients that benefited the most and have the longest progression-free survival, of course, it is the subset of patients with the, with the upfront surgery without any residual disease. They have progression, pretty impressive, progression-free survival of nearly 14 months, which is exceptionally long for ovarian cancer. This is probably one of the most important slides, and it's kind of an illegal slide, because in this slide, there's been quite a fancy statistic performed where they tried to compare the PRIMA trial with the PAOLA-1 trial. So they did indirect comparison of these prospective trials, did some propensity-weighted matching in the population, and tried to select and modulate patients from the PAOLA-1 trial to this PRIMA criteria, so kind of this high-risk subset of ovarian cancer patients. And there you see the patients broken down by biomarker. So on the left-hand side, we see HRD positive patients, so patients with tumor which an HR deficiency. And when we look here, what is the treatment line or the maintenance treatment for these patients, where patients get the largest benefit out of it, then it is a PARP inhibitor plus bevacizumab with a median PFS of 36 months. Then in the HRD positive patients, followed by the PARP inhibitor mono maintenance therapy, followed by bevacizumab mono, and the worst prognosis for patients without any maintenance therapy, only receiving placebo. So in the HRD positive group, PARP inhibitor is the most important aspect or asset of a maintenance therapy. And on the right-hand side, you see the HRD negative patients, so patients without any HR deficiency in their tumors. And there you see that the important aspect is in these patients bevacizumab, where you see that PARP inhibitor plus bevacizumab has nearly the same line as bevacizumab mono maintenance therapy, followed by PARP inhibitor, followed again by placebo. So we kind of have very precise predictive biomarkers for PARP inhibitor. And then as kind of the final aspect, what about immunotherapy in epithelial ovarian cancer? We have some prospective randomized trials. The most prominent one and the one we were most hoping for was the Imagine 50 study. Of course, this is our hope to not only turn epithelial ovarian cancer in the ideal setting into a chronic disease, but to really increase the cure rate. And with surgery, we are kind of reaching our bar with respect to the aggressiveness, what patients are able to tolerate during surgery. So we need definitely better treatments, targeted treatments for these patients. And that was what we were hoping for with atezolizumab, that was added in the first-line setting in these primary high-grade epithelial ovarian cancer patients. So they received the classical, typical 6 cycles of carboplatin, paclitaxel, and then bevacizumab in both cohorts, and on top of that, either placebo or atezolizumab. And unfortunately, when we look at progression-free survival, in the ITT population, as well as in the biomarker stratified cohort with the PD-L1 positive population only, absolutely no difference between the two cohorts, whether they receive atezolizumab on top of bevacizumab or not. The same for overall survival. No difference between the two curves, be it for the ITT population as well as for the biomarker subgroup population. And then we tried to grab a little bit of information and maybe identify at least a little subgroup of patients that could potentially benefit from this treatment. But again, absolutely no benefit, no subgroup of patients that benefited from the atezolizumab treatment. So that was kind of a huge disappointment for us to see that. But still, the pages are not closed on the topic. And when you look at the maintenance therapy options that are currently tested in randomized controlled trials in epithelial ovarian cancer, you see that a lot of PARP inhibitor trials, of course, but it is kind of all of combination maintenance therapy. PARP inhibitors plus bevacizumab, PARP inhibitors particularly plus checkpoint inhibitors. There are some intriguing phase 2 studies where the efficacy of checkpoint inhibitors in epithelial ovarian cancer were significantly increased by the addition of PARP inhibitors. And you see that these trials are run throughout the whole lines of ovarian cancer, be it from the first line to platinum-sensitive setting, to platinum-resistant setting, second recurrence, and late-stage disease. So my take-home messages for this talk would be that nowadays every ovarian cancer patient will receive at least one maintenance therapy, and it's not a question of whether they should receive maintenance therapy or not, and be it in first line or in recurrent setting, but it's like only a question what type of maintenance therapy these patients will receive. When you have a patient with a BRCA mutation or with an HR deficient tumor, they will need to receive a PARP inhibitor at least as part of the maintenance therapy. That's crucial. And at the moment, there are two like kind of burning questions we have when we treat patients with ovarian cancer, and that is question number one: what about the role of PARP inhibitors after PARP inhibitors? So can we reintroduce PARP inhibitors in the lines of our sequence of our treatment for ovarian cancer, as we can do it with bevacizumab, where we get this stable 2 to 5 months benefit for our patients? And particularly this second question, at least equally important: what's the role of immunotherapy in ovarian cancer, where we have not really found out where to put it and how to combine it? So thank you very much for your attention. I'm looking forward to your questions.
Thank you very much. Are there some questions? So I have one question. So I'm a dermatologist. I was wondering, when we are talking about immunotherapy, we are only talking about PD-1. What about CTLA-4?
There are some promising trials, phase 2 trials. The double combination, dual blockade. There's been like kind of the first signals that there's some efficacy in epithelial ovarian cancer. And that's so the Imagine 50 was a pretty aggressive trial because they really like kind of wanted to introduce it first line, all comers, maybe just with PD-L1 subset analysis, but it was very aggressive. So I think we kind of learned that in epithelial ovarian cancer, we have to do either a dual blockade with a combination, or combine it with PARP inhibitors, where we get a very interesting signal. And I think that's maybe in epithelial ovarian cancer the way to go, with checkpoint inhibitor plus PARP inhibitor.
Okay, thank you very much. Yes, please.
Did you check in Imagine trial how high was tumor mutational burden, especially those group who have homologous repair deficiency? There could be a subsample of patients who benefit.
Yeah, absolutely. That's a perfect point. That's something that we addressed, and we have not got. Unfortunately, that was not identified in this patient. So they went into the samples, and they are doing subgroup analysis with tumor mutational burden, BMI, and I think 2 other biomarkers. So they're trying to identify a subset, but it was not a pre-planned analysis. So that's a question that we have not addressed at the moment.